Alright, let's get started. I want to begin by saying I'm excited to be here day one. It's a great start. This is a 2-semester class, and we're starting today and we're going through next April. So it's a marathon, not a sprint. And believe me, it's a marathon. But it'll be fun. Anesthesia course nowadays is pharmacology. That's basically. We don't hit people over the head with a baseball bat. We put them to sleep with drugs. And you scratch any anesthesiologist or CRNA, we present them with a problem in the OR, and the first thing they try to think of is, what drug can I give to get myself out of this? Or to make it better, and make the patient recover. So we do with drugs pretty much everything. And so this is going to be the class that teaches you how to do that. And I'm going to teach you how to put someone to sleep. You're going to learn anesthesia in the OR. I can't teach you the actual handling patients, but I can certainly give you the why. You learn the what from your clinical preceptors when they get in the operating room. So it's going to be fun, and I'll start right away as fast as I can. Usually within the first 4 classes, I'm done rambling on, and we're ready to start anesthesia drugs. And so that's that. A little bit about myself, just briefly. I obviously a CRNA. I went to Virginia Commonwealth University in Richmond, Virginia. Still there. Became a pharmacologist, PhD in pharmacology from Wayne State University in Detroit. And I've been out here at Kaiser since '96, so it's my 21st year at Kaiser in Los Angeles. And I've taught this class, I forgot how many times. But it's fun. And I think hopefully you're going to enjoy it as well. Now, what I found over the years is we have a couple of barriers to get through, little ones, but kind of barriers. And they're inevitable. The first one is that the path to becoming a nurse is not very linear. What I mean by that is you can be an ADN. I was an ADN, and or you can go to a BSN, or you can go to nursing as a second career, accelerated class. A lot of folks do that. Everybody's got a different degree, and a lot of you people became nurses in a different manner. So your pharmacology background as a nurse is all over the pages. Some people have real formal, semester-long lectures for 1 or 2 years in a row about pharmacology, and they've had a lot of background, and that's all good. Other people, literally tell me they did modules on their own on the internet or at a library and wrote little drug cards and tried to remember everything and memorize them, and of course they never could remember them. And then, so they had kind of a weak pharmacology background. So because of that, I always spend the first 4 classes doing kind of a intro to pharmacology beginning, so that we're all on the same page. Any science, biochemistry, pharmacology, anatomy, physiology, you name it, is really a language. And in order to understand the science, you have to understand the lingo. And there's a lot of terms in pharmacology that we use: half-life and volume of distribution, and enzyme induction and metabolism and all kinds of stuff. And so there's a lot of different definitions and words that have great meaning, and my objective is to spend the next year having you learn all that. So everybody comes from a different background, and that's why I kind of like to start with a basic. This is pharmacology. Some people it'll be kind of basic for, others not so much. And the other inevitable thing is, of course, nursing, medicine, pharmacology, as you'll see in a few minutes. They all have specialties. You're a physician, you go be an endocrinologist, or a pediatrician, or a surgeon, or whatever, obstetrician. So you specialize in a specific area. Nurses do the same thing. You worked in CT/ICU, so you're going to know all the cardiac drugs we go over pretty well. But maybe not so much about the renal drugs, because you didn't do renal patients much, or or the thoracic, or the neuro patients, and so on. Just because you just haven't used the drugs as much in your nursing career, you didn't need to. So because we nurses specialize, just like physicians, and just like pharmacologists, as you'll see here in a minute, then maybe you just haven't had a chance to run into a lot of them in your nursing career. And of course, the big kahuna is this. The anesthetic drugs nobody runs into because they're not prescription drugs, and most pharmacology books don't even have chapters about anesthetics. They are drugs that are, they come in a box and they're delivered to the pharmacy in the basement of the hospital. And they ship them up to the anesthesia department. They don't even open the box. Most pharmacists aren't familiar with the anesthetics. They have a little bit of familiarity, but not much. So these are very specialized niche drugs. They're given in front of somebody that's been trained for years to give them and to adjust their pharmacology minute by minute, breath by breath, second by second, and then to make sure they're all gone before the patient goes home. And just think of what a difference that is to the real drug world. If you watch television for more than half an hour nowadays, you hear sustained release, patches, once-a-day dosing. The whole world in pharmacology is trying to get drugs that you only have to take once in the morning, and it lasts for 24 hours, or for a week, or for, I know several women that take the biphosphonides for their osteoporosis prevention, and that's a once-a-month drug, pill. So, I mean, you're trying to take them as little as possible. Why? Well, the FDA has done a ton of studies, and they know that the compliance is much higher the less frequently you have to take the drug. If you only have to take it once a day, then patients will pretty much follow that okay, somewhere around 80%. If it's a TID drug 3 times a day, or QID, then the compliance falls to 20–25%. That you can get this actual drug taken at the right time, every day, correctly. So the big push is to try to get drugs to last longer, and that's exactly the opposite of us. We want drugs that start instantly and that are gone in a matter of seconds. You think about the performance pressure that we're under. We have to put the patients into a drug coma in the operating room, and then we have to wake them up, take them to the recovery room. 30 minutes later, they eat a cracker, they swig a little orange juice, they put their shoes on, and they're out the door in 30 minutes. And then, hey, it's nice, make sure you pay your bill, let's do lunch. So, I mean, that's what the thing we're facing in a modern operating room. So we have to put people into a coma, keep them there for how many hours the surgeon wants to mess around, and then wake them up right away and send them safely home with no side effects and no drug left over and any sort of problems. So it's a challenge. Of course, we can do it, and that's the way the modern anesthesia works. But we're the opposite, I guess, is my point, is we want drugs to work right away. You'll see that as we go through these 2 semesters, we'll talk about a drug, the onset of action is 30 seconds, and nobody uses it because it takes too long. Yeah, what are you talking about? Well, that's just the way it works in the modern world. And also, we want them to go away immediately. Now, we don't have all of those, perfect drugs by any means, but that's what we would like if we had the choice. So we're a little bit different. Our drugs are given by professionals, witnessed, adjusted, and so on. The average drug is, in fact, given by prescription, so some doc or NP writes a prescription, patient goes to the drugstore, gets a little brown bottle full of pills, hopefully takes them correctly according to the label, and when they go home, if they have a side effect, then they call a doctor back or the pharmacy or so on. So that's the 99% of drugs taken in the world. That's how they're adjusted. For us, it's different. We stand right there, we give some more, we take some less, we adjust it up and down, whatever. So it's a very, we're kind of an oddball in the pharmacology world, as I'll show you a little bit as we go through the book. So, that having been said, my whole point, and I do have a point, the way that we can get us all on the same page is I'll spend the next 3 to 4, probably 4 lectures just doing an intro to pharmacology. Let's learn some terms so I can talk, lingo, the drug lingo. Let's learn some terms together, and even if you had them before, it'll be a nice way to refresh, and so on. And then immediately, I promise, we're going to get into anesthesia, because we're going to have to get you in the operating room, putting people to sleep relatively quickly. So if you want to look at your workbook, on page 1 of the workbook, this is Pharm 1, and you'll see that as far as the logistics of the class, I'm going to give 3 exams. So I'm reading on page 1. There's 3 exams, each of them worth 20% apiece. So 3 times 20 is 60%. And then there's 1 final exam, and I'm going to make it twice as costly. So that's 40%. So there's 4 exams total, 3 exams and a final, equal 100% of your grade. Obviously, it's cumulative. You're going to have to know this stuff for the rest of your life. This isn't just like your usual pharmacology class where you take it and then you forget it the day after the semester ends, and then you remember it when you go be a nurse. This stuff is your bread and butter of what you do every day. And you'll see this is a very practical class. It won't seem like it at first, but very much what I talk about in this class, you're going to go in and do on a daily basis. So you're going to need to know this all. There's the book and the workbook, and you'll see I have 2 outcomes I put, or objectives for the class, and it's pretty simple. Number 1, I want to teach you the language of pharmacology. You're going to have me for now till next April. So what's that, 9, 10 months? Man, it's a long time. Day 1. But of course, you're going to have a long career, decades. So what happens when a new drug comes out, and some drug salesman comes to you and says, this is the best anesthetic they ever made? You got to need this to take in the OR and give it to your patients. So how are you going to be able to evaluate that in comparison to what we currently use? Is it worth your trouble to have to learn what you need to learn to give it, and so on and so forth? So I want you to have enough background. You can think about somebody my age. Very few of the drugs I ever learned on are still around. It's a whole new world now. And any CRNA or anesthesiologist can tell you the same thing. That things change, and so you need to have a background to be able to assess pharmacology and drugs in the real world. And then number 2, my objective is to just teach you anesthetic pharmacology. There's a certain basic minimal knowledge that any clinician, CRNA or anesthesiologist, knows that in order to give anesthesia in 2017, you need to know this stuff about the drugs. You can't give this drug to this person. In this kind of case, you use this drug. When you have this problem with the heart, you give this drug, and so on. And we all have certain basic knowledge that we all have, and we spent many years in college learning it, but we all have it so that you can safely practice anesthesia. So I'm going to teach you the basics of anesthetic pharmacology, and also, hopefully, enough general pharmacology, terminology, and so on, that you can have it for the rest of your career. So those are my 2 objectives, and I hope to be able to do that. If you go to page 2, you'll see I made this little scheme, because it's me just making it up. And primarily I did it so that I don't go off on too many tangents. I do this mostly to keep myself in walking down the middle of the road, because I tend to get kind of crazy. But when we start going through the anesthetic drugs, we'll start with the gas anesthetics and the IV anesthetics, and narcotics, muscle relaxants, local anesthetics. We're going to do all that stuff. Then for each class of drugs, I'm going to go through categories 1 through 11. And I just kind of made these up. I'm on page 2. Number 1 is the classification. How's the drug classified? Number 2, a little bit about the history of the drug and where it stands nowadays. I've never asked you a single question about history. I don't care about it, but I just want you to have some context. Number 3, structure activity relationships. And that's the chemistry of the drugs. And there's one thing that we can't get away from, and that is that drugs are chemicals. And everything to do with pharmacology has to do with chemistry. People hate chemistry. Nurses hate chemistry. You probably hate chemistry. But we got to do some. I'll try to make it as painless as possible. Number 4, pharmacokinetics. And that's pretty much what we do every day in the OR. And as we'll talk about the different areas of pharmacology in a minute, but kinetic is movement. And so pharmacokinetics is the movement of drugs in the body. And what we do when we go to work is we move drugs in and out of the patient. And we need to know, second by second, breath by breath, minute by minute, where these drugs are. We don't just squirt them in the IV tubing and then just wait to see what happens. Right? We know what point after we gave it, where is it going to be in the body, how's it going to be metabolized, how's the patient going to excrete it, and so on. We'll talk about that in great detail. Certainly number 5, preparations and doses. You got to know how the drugs come, how they're prepared, and what the doses are. 6, a little bit about the pharmacology. Many drugs we know how they work, many we don't. So the pharmacology means the mechanism of action. If we know how it works, we'll say. If we don't know, we don't know. And then what happens at different doses. And that's an important part of anesthesia as well, because you got to give, uh-oh, the patient's moving, I got to give a higher dose or whatever. Or, uh-oh, I want the patient to move at the end, I better get the dose down. So what happens at different doses. Number 7, the different effects on the various compartments in the body. I start obviously with CNS and autonomic because that's the thing we play with the most, is the brain. But heart, respiratory, renal, GI, endocrine, biochemical, etc. Number 8, we'll do separately about the OB administration. CRNAs do most of the OB anesthesia in America. We do about 70% of it. So you're going to deliver a lot of babies in your career. Actually just give epidural so that the obstetric, or the OB-GYN, or the midwife can deliver the babies. But we do a lot of OB anesthesia. So we have to look at, is there special considerations for giving this drug to mom? Is it going to go to the fetus? And, so on and so forth. And then also pediatric on number 8. Is there special pediatric issues when you're doing kids, anesthesiaing kids rather versus adults? Number 9, what about the toxicity? And unlike most people in the drug world, we have to actually deal with the toxicity. If the patient takes a prescription at home and they get a rash, chances are the doctor's not going to know that. Maybe the pharmacist will. Maybe he'll call a nurse in the doctor's office or whatever. But if we do have a toxicity or side effect, it's going to happen while we're standing there, and we got to fix it right away. So what about the acute and chronic side effects? What about contraindications? Who can't you give the drugs to, this particular drug to? And of course, possible drug interactions. How do you treat adverse reactions? That's a lot of anesthesia, is how do we treat bad things when they happen in the operating room? And then what's the current use in clinical experience? And for that, I mean, you learn about what they say in the books, but this is what the real world, when you go in the operating room tomorrow, this is what people are going to be doing versus what they said in the book. So we'll do a little bit of that too. So that's what I'm going to try to follow once we get through my little introduction, and it'll give you a way to kind of see where I'm going with a lot of this stuff. On the next page 3, here's the schedule for the class. So you'll see that for the next couple classes, there'll be introduction, general principles, and so on. And then we're going to start right away with the gas anesthetics. Our first exam, for example, will be Friday, October 6th. The days we have exams, there'll be no video class. And exam 2 then is November 3rd, and so on and so forth. Get a couple days off for Thanksgiving, and then the final will be the first week of December. So there's the schedule. Again, every one of these classes is taped, and I have a system called MediaSite that's running right now. And what happens is, when the class ends, it converts it to some kind of file, I don't have any idea, about the technology of it. Clinton does. And it posts it up on the internet. And it takes about 30 minutes. So if you wait till about 10:30 in the morning, California time, it'll be posted up on the internet, and then you can just watch it at your own 24/7. I'll leave it up there for a couple of years. So we are recording all this, and so if you feel, oh my God, what was he talking about? I better go listen to it again. You have a chance to do that. And the nice thing is you can fast forward through me too. So that's the schedule, and on page 4, of course, is my contact information. There's my name, address, every kind of phone number, email, and I strongly encourage everybody to get a hold of me, or call me, email me, whatever. I have daily emails from people all over the country to talk about drugs. It's one of the fun things I do. At my age, I don't have a lot of fun, so that's one of them. I have people that I taught years ago. They'll be doing a case and they'll get some kind of weird reaction to a drug, and they'll shoot me an email. Oh, you should have seen what happened when I gave the patient this. This is, the left toe curled up and their hair turned red. Or anyways, I get a lot of interesting drug discussions from previous students, and I enjoy that. And if you email me, I'll try to get back to you the same day, by the very least the next day. For those who are doing the video conference live, if you have any problems, this is technology. Technology is not perfect. Sooner or later, you're going to drop off the lecture, or something will happen and the computer will blitz. Then you can call this number, 1-877-358-4336. It'll say 1 to schedule, option 2 for tech support, do option 2. And they'll get you hooked up. There's the instructions from Clinton on how to get onto my webpage and see the lectures and download. There's Clinton's contact information as well. So if you want to get together with either of us, we can help. Okay, page 5. I found this in a book somewhere, and so I just stuck it in here this year. This is page 5. These are little computer resources that you can have on your phone or whatever, and that give you some medical information. I know that a lot of people like to use Hippocrates, for example, to look up a dose, or to have some information about contraindications or whatever. And so I thought this was kind of a nice little thing. They tell you what type of thing it is. It's an app or a website. Is it free or not? I always go for the free ones. So I just thought it might be useful to you. I use Medscape all the time. I think it's one of the best as far as medical information. Not especially drugs. It's good for drugs, but more for medicine. And but anyways, that's just for your own benefit there. And then page 6, of course, I found these cartoons. I thought I'd throw them in here because a lot of it's true. And as the young lady says, every adverse effect in pharmacology is either nausea, vomiting, or diarrhea. And I stuck it in there and I laughed because when I was a pharmacology student many moons ago, when somebody wanted to know about side effects, we knew we could always write this. And it goes along with this, you can always write anorexia too, because if you're nauseated, you're vomiting, and you have diarrhea, you don't have an appetite. Trust me. So there's always the 4 things that could write on a test that we had to come up with some kind of side effect, Because even placebos, they'll always have a certain number of people that have that. So that was good. And the last one, of course, that little brain there, studying pharmacology, it's like memorizing a dictionary. And I hope I'm going to make it not like memorizing a dictionary. I know some people think that. But we'll try to make it a little more exciting than that. Does anybody have any questions? Did I forget to say anything? Textbook, tests, contact information, all that stuff I'm supposed to say on the first day? If I did, please let me know. and we'll go from there. Now, on page 7, where do you start? Well, why not just defining what pharmacology is, as we're starting from the beginning, then let's do that. And so I decided, well, I'll look in a book and see what they come up with a name. So I start at the top of page 7, Intro to Pharmacology. Pharmacology is the study of the effect of chemicals on living tissue. So that's a pretty broad definition, and I think everybody could kind of agree with that. But it certainly is broken down into many different specialties. Now, there's a little over 10,000 drugs on the market currently in America, formulary. You obviously can't be an expert in all of them. And in fact, you're usually an expert in a very few of them. So pharmacologists, like physicians and nurses and so on, specialize in particular areas. You're a cardiac pharmacologist, you're a respiratory, you study Parkinson's disease, or you specialize in drugs for chemotherapy or whatever. But some of the broad areas of pharmacology that we're going to touch on in anesthesia is number 1, and I have them here listed, starting with pharmacokinetics. And as I mentioned, pharmacokinetics is a big area for us, because we have to move drugs in and out of the patient's body all the time. We're giving 5 or 6 different drugs at the same time. They all have different onsets and durations, and we're kind of balancing all their administration together. The definition, as you can see on page 7, is the study of the absorption, distribution, metabolism, and elimination, excretion. So those 4 sub-areas are what kinetics are. Absorbing, let's get the drug into the body. How do we do that? Almost all of our drugs we give IV because our patients are asleep. Can't get them to swallow pills. Or inhalation, because that's how we give the anesthetic gases. Distribution, where does it go once we get it in there? How do we, usually we want to get it in the brain, because that's where we're trying to put you to sleep. How is it metabolized, if it is metabolized, where it's metabolized, then finally how is it eliminated or excreted, and we're going to spend inordinate, probably the most amount of time discussing that than any other aspect of pharmacology. Pharmaceutics is the field of preparation of drugs, and the pharmaceutics experts that work at a drug company are the people who decide, is it going to be a pill, is it going to be a capsule, is it going to be this big, is it going to be blue, is it going to, whatever, is it going to be an injectable, is it going to be a spray? The pharmaceutics people figure out, how can I get this into the body? They look at all the holes in the ears, nose, throat, whatever. All right, there's a hole, let's see if we can stick a drug in there and get it to, figure out where it's going to go. So pharmaceutics is the formulation and the preparation of drugs. Why are they what they are? Why is the drug a tablet or a capsule or whatever? Pharmacoeconomics is pretty obvious. It's the study of the economic impact of drugs, and this is obviously a major area in medicine, modern medicine. There's this week I was just reading a big announcement. They came up with the first drug that seems to be able to cure leukemia, one subtype of leukemia, and it's $500,000 for the treatment. So if you're a hospital system, say for Kaiser Permanente or any one of them, and you want to make this available to your members, your patients, that's a $500,000 a dose of drugs. It's more than one dose, but you can see that the economic impact of that would be tremendous. So there's a lot of economic issues with drugs, and we won't get into many of them because ours are pretty cheap. Toxicology, of course, is the study of the toxic effects of chemicals and harmful effects. We like to think that toxicology is the pharmacology of high doses. You're given too much, you're going to get toxicity. Pharmacognosy. Pharmacognosy is the study of deriving drugs from natural products. So getting a drug from a plant, ephedrine, digitalis. They come from plants, right? Botox comes from botulinum toxin. Many tamoxifen used to treat cancer. It's from the bark of trees. So there's a lot of drugs that come from the world, from fish, from plants, from trees, from the environment in general. Many of the famous drugs, morphine, of course, opium. Pharmacology is the field that tries to find medicinal uses of natural curing compounds. Pharmacy is the preparation and dispensing of drugs. So strictly speaking, a pharmacist dispenses drugs. Now, of course, they are very knowledgeable and I think underutilized in the medical world. But nonetheless, strictly speaking, it's the preparation and dispensing. Pharmacogenetics is one of the newer areas, and that's, of course, the genetic influence on drugs. We have some very important ones in anesthesia, and we're going to learn those. In fact, one of the first ever was atypical acetylcholinesterase found with one of our anesthetic drugs. So this is a study of what about the patient's genetic makeup that will make them respond to a drug differently than you would expect, or respond in a certain way. And there's a tremendous amount of information now about genetics. We, in fact, are starting to prescribe according to the patient's genetics, and we'll talk a lot about that as well. Pharmacodynamics, another big area for us. Pharmacodynamics is the physiological and biochemical effect of drugs. When you give a drug, what's it going to do to the patient? That's the pharmacodynamics. This is what all the drug books always say. It's kind of cutesy, but it works. Pharmacokinetics is what the body does to the drug. Pharmacodynamics is what the drug does to the body. If I give you a drug and your heart rate goes down to 40, that's a pharmacodynamic effect. What did the drug do to the body? If I give a drug and the liver metabolizes 80% of it, that's pharmacokinetics. That's what the body did to the drug. You'll see the distinction as we go along. Genomics, pharmacogenomics is studies of genetic influences in populations. There's a lot of that. We'll study, people of certain descent, Alaskan, the Indian populations in parts of Alaska respond differently to this TB drug than patients in the Middle East, and there's certain populations that have very well-known effects, drug effects, compared to other people, and we'll get into some of that as well. And then finally, pharmacoepidemiology, and that's the study of the use of drugs in large groups of people. So these are kind of the sub-areas that we're going to get into. Of course, we get into cardiac and respiratory, and that goes without saying, those sub-areas. But these are the kind of pharmacologic areas that we're going to get into. Then this little diagram that I put in here on the bottom of page 7, I thought it was kind of cute. And they're talking about the various areas of pharmacology, starting in the middle of this with pharmacology, chemotherapy, biochemical, kinetics, molecular, and then they share all the little offshoots of all the different kinds of pharmacology areas that you can study, subdivisions, and so we're going to try to get into as many as possible. Now on page 8, I don't know why I put this in here. I liked it at the time. This is just a little diagram from an anesthetic book showing you, our job is we take drugs in a syringe or in a vial, we give it to a patient, we have to deal with the kinetics and get it to where we want it to go, and then eventually it's going to get to a drug receptor and produce an effect. So they're talking about the different domains. Let's read what he says in the description. The general scheme of clinical pharmacology is divided into the dose, concentration, in other words, what dose what blood level did you end up with? And then the effect domain is what happened when it got to the receptor and produces an effect. And so the kinetics is getting it there, you see in the bottom. Biophase is when it's at its receptor, and finally in the bottom right. Pharmacodynamics is what does it do to the receptor? What does it do to the patient? And we'll spend most of our time talking about receptors. We'll get into that in a minute. Some of the unique aspects of anesthetic pharmacology at page 9. And why we're a little bit different in the pharmacology world than many people. And this, I found this in a book as well. I didn't write this. But the unique aspects of anesthetic pharmacology is, number one, we have very narrow therapeutic. In other words, our drugs are very potent and very toxic. If you don't give it right, you're going to kill somebody. Right? It's not going to happen in the modern world. We know exactly what we're doing. That doesn't, But if somebody was not an anesthetist and tried to do it, they wouldn't have a success. There's severe consequences for either under or overdosing, and you got to adjust the level frequently depending on what the surgeon's doing, what part of the case is. Are they still on their way in? Are they yanking on somebody's organs? Are they cutting somebody's bones? Are they doing whatever? And so are we getting near the end, etc. Efficiency issues, of course, I mentioned already. We need a fast onset and fast offset. And then finally, how do you figure out the dose? Posology means dosing. How do you determine a dose of an anesthetic? Well, when do you need it to work? How fast? How long is the case going to last? And so on. And it goes through all these different parameters you have to take into consideration. We just do this naturally. We don't even think about this. This is just a natural part of us going to work every day. And you walk in, they say, okay, Mary, you're in room 7. You're going to be doing gallbladders all day. Yeah, yanking people's gallbladders out. Oh, that's exciting. So you're going to do lap choles. So you go in there and you automatically realize, well, with gallbladder, I'm going to have to make sure I do this, 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 and this. Get them out safely, make sure they get out of the hospital quickly, and so on and so forth. So these are the kind of things that we just kind of look at naturally. When will repeat doses or boluses be given? How should I administer the drug? By continuous infusion, by intermittent bolus? What concentration am I trying to get? Is the patient going to develop tolerance? Et cetera, et cetera. And you can look through those. Now, lastly, this is an article, page 10, that I copied from one of our journals in pharmacology. It's called TIPS, T-I-P-S, Trends in Pharmacologic Sciences. There's the reference there, 2016. And it's written by a couple of anesthesiologists from Harvard Medical School. And they talk about the development of new anesthetics. And in fact, they're lamenting the decline of the fact that we haven't had any new anesthetics in a long time. Why? And they go in for reasons for this decline. And they first talk about how, in the beginning and back in the 1960s, 70s, 80s, and so on, there was constantly putting out new drugs, bigger and better, newer, improved, et cetera, et cetera. But now you can see in the second paragraph they say, fewer new drugs were approved in anesthesia over the past 30 years than during the previous 30 years. Among the anesthetics in use today, 4 were introduced in the 85 to 2014. Less than half that were introduced 55 to 84. Since 1990, there's been no new investigational drug for inhalation anesthesia and only 1 possible IV drug. So since 1990, we have had no new anesthetics. Wonder why? Well, let's see what he says. Reasons for this decline. The first one, he said, is, and this is a very obvious one, because we don't know how the anesthetics work. We don't know the mechanism of action. We know what they do. They put you to sleep. Obviously, we know all about that. We can do that with such exquisite precision. It's unbelievable how well we can do that. We have no idea why. If we knew how the drugs worked, it would be a lot easier to make new ones. That's true of any drug, right? If you know the mechanism, you can develop newer drugs for the receptors and so on. So that's a problem. Number two, there isn't much of an incentive for the drug world, drug companies, to come up with a new anesthetic. Give small doses, as he mentions, and give them once. You may have an operation once in your lifetime or twice, you know, whatever. Hopefully, zero, but at least just a handful. And if I'm a drug company, I want to work on a drug for hypertension that you're going to take it twice a day for the rest of your life. There's a drug for me, right? Not some anesthetic where some guy's going to give, or a gal's going to give you 100 milligrams once in your 30s. How much money you got to make off of that? None. So the drug world spends all their time, most of their time, working on drugs for chronic diseases, Parkinson's, Alzheimer's, you know, or arthritis, cardiac, whatever, because that's what the money is. And then lastly, he feels, hey, I think there's some truth to this on the next page 11, the safety has been achieved by improvements in how we give anesthetics. In other words, even though we don't have real good anesthetic drugs, we have pretty good drugs, but not perfect drugs. We could certainly make some improvements. And you ask any CRNA or anesthesiologist practicing, and they can, right off the bat, off the top of their head, name 10 things they would like the drugs to be able to do better than they can do now. But we've become so good at giving them that we can work, you know, we workarounds for the problems that are there, that we're actually made anesthesia tremendously safe. Anesthesia is one of the most safest specialties in medicine. We have one of the lowest malpractice rates for medicine. And that wasn't always the case. When I started way back in the 1970s, we were way in the top. The orthopods, the neurosurgeons, and anesthesia folks were way up top. Now, we don't even register on the screen. It is so safe to get anesthesia. And we have so few side effects and issues, serious issues, I should say, that we're not on the radar anymore. And that's because we've been really good at making equipment and machines that can give these drugs and compensate for their weaknesses. And we're good at recognizing potential problems and fixing them before they happen. So anyways, he concludes that it would be great if they could come up with a new anesthetic, and it could certainly revolutionize anesthesia if they did. It's ripe for the taking. We haven't found the drug yet that's going to be able to do that. We had a new one, Gamodex came out this year, first new drug in about 20 years. And that's kind of revolutionary, but it's got a real niche use. But you'll be giving that, and that's been a real plus. Okay, let's take a break, maybe 10-minute break, and I'll see you in a few minutes.
Not American. Oh, soccer. Spanish league. Whatever you like. American football. Oh, Lakers.
Okay, let's get started again. Got quiet fast. All right, let's go to page 12. Page 12. And let me mention, somebody asked me, rightfully so, on the break. I didn't mention anything about the tests. And I will. When we get a little closer, I'll go through what's going to be on and how to get ready for it and so on. If you talk to anyone who's taken the class previously, you'll see that I'm a big believer in telling you what I want you to know. Exactly. Don't make a guess. If you want people to know something, say, go learn this. This is what I'm going to ask you. This is the answer. Go learn it. So I'm going to do that for a lot of this. So you'll see when we get closer to the first test, maybe the week or so before, I'll talk more about it. Okay, page 12. Now I mentioned that what I want to do for the next couple classes is to talk about the kind of 4 introductory areas that we can get some terminology together and then be ready to roll when we want to talk about anesthesia. And these are areas that I've just picked up over the years that I think it's useful for you to know something about before we start learning about the gas anesthetics and how do you put someone to sleep. And so the 4 areas are, first of all, receptor theory. That's pharmacodynamics. Secondly, some kinetics, absorption, distribution, metabolism, and excretion. Number 3, a little bit about the autonomic nervous system. You're going to learn it in physiology and by many other people. But in pharmacology, we have a different kind of a lingo associated with it. And we spend most of our time in anesthesia pharmacologically messing with the autonomic nervous system, adjusting it and so on. We spend very little time worrying about consciousness. We put you to sleep, you're asleep in 5 seconds. All right, so the other 3 hours the case goes on, I'm not worried about your awake or sleep. All right, in anesthesia, all of our drugs in the drawer put you to sleep. That's like, oh, he put you to sleep. Oh, we all look at it like, yeah, okay, of course we do. That's what we get paid for. So what we do when we're there for the 3 hours is we're messing with your respirations and your heart rate, and your blood pressure, and your vascular tone, and your fluids, and so on and so forth. And that's all autonomic nervous system stuff. So we're going to spend a lot of time on that. So I want to get some terminology there. And then number 4 on page 12 of my introductory areas is anesthetic goals. And what I mean for that is I don't want to take anything for granted. And so I put it this way. Say your next door neighbor comes and knocks on your door. Hey George, I got to have my knee operated on. I tore my ligaments on Monday. Will you give me anesthesia? All right. In the modern world, 2017, what exactly are they asking you to do? I mean, anesthesia is a big term. What does exactly it mean to give anesthesia to somebody pharmacologically? What are you trying to accomplish with the drugs we give? And so on and so forth. In the old days, and I'll show you some movies of this that are kind of funny, they would give one drug, ether, maybe, or something, you know, back in the bad old days. You got one drug for the whole operation. But nowadays, we'll give 5, 6, or 7 drugs at the same time. Just tiny doses of each. And we do it because it's easier to control your level that way. This way, it's easier to wake you up at the end. That's probably what we're worried about. Not worried, but I mean, that's what our goal is. It's easy to put someone to sleep. You give them a big enough dose of propofol, and I guarantee you everybody will go to sleep. And you'll look like a genius. The question is, can you wake them up? And promptly and safely, and get them extubated and get them off to the PACU, and so the patients recover and they're not throwing up off the side of the bed. Then the PACU nurses are going, oh no, I'm not going to take his patient. They're talking about you in the coffee room. And so you want to be able to do it safely. So that nowadays we give a bunch of drugs, but you give little amounts. We can get rid of them easier that way. Reverse them, let them wear off, whatever else we're going to do with it. And so we give a kind of a balance of drugs. And you'll see what I mean by that. So what are the anesthetic goals in the modern world? I'll talk a little bit about that at the end. So let's start with introductory area number 1, and that's receptor theory, pharmacodynamics. And I'll say this. Way back when, early 20th century, 30s and 40s and so on, they were doing animal experiments, and famous scientists at the time, well, he became famous, he wasn't at the time, noticed that when he squirted certain chemicals on various frog hearts and so on and so forth, you'd get a response, tachycardia, bradycardia, whatever, And he came up with a theory that there must be something in that frog heart that's receptive to me giving the chemical. There must be a receptive substance somewhere in the heart that recognizes that I just dripped this chemical on there and makes us heart rate slow down. So he postulated that there must be receptors, the receptive substance that's there to recognize the release of certain chemicals and to have a response. And it sounds very basic, but at the time it was pretty revolutionary. Now I jump up to 2017, and of course we know there's receptors. There's receptors for everything in the body. In fact, that's how the body works. There's chemicals, neurochemical transmission. That's how all information transfers in the body. The brain sends a signal out that squirts a chemical out of a nerve. That chemical stimulates a receptor in the various tissues and makes something increase or decrease. My mentor in pharmacology, Dr. Fred Buthen, used to tell us all a drug can only do two things. Make something go up or make something go down. That's it. That's the mechanism of action of all drugs. That went up, that went down. Maybe if it didn't do anything, you could say nothing. But it's pretty simplistic, but true. And developing that, one of his main points was that a drug can't make the body do anything it can't already do. Right? I can't take a drug and jump over an 8-story building, right? Because people can't jump over 8-story buildings, drug or no drug. Right? I can't take a drug and make my heart rate go up to 400. My heart will never go to 400. I die. All right. So if you take a drug in the body, the drug can only make the body do something it can already do in the first place. Maybe it enhances or it inhibits or it replaces. It does all those things. But the body's got to be able to have that function there in the first place. And that function will have receptors that make it happen. So there's a receptor in the body for every physiological event that occurs. A receptor of some kind. And what pharmacology, the field is, or a pharmacologist, does is tries to mimic the body's own chemicals or stimulate those receptors or inhibit those receptors or whatever for some therapeutic benefit in the patient. But the point is, a drug can't make your body do something it already can't do. It can only work on receptors that are there. So if I say I take a drug and it makes me breathe faster, then there must be a receptor in my body to make me breathe faster. And I took that drug and stimulated that receptor. In other words, everything we're going to make the patient do, they can already do. We're just going to single it out or manipulate it or whatever. Now the way we're going to approach some of this, and we'll get into this in a minute, is we're going to just learn the receptors. The way in those jokes I showed you on page 6, and they're true, and I don't disagree. But one of the problems with studying pharmacology, if you just try to memorize this drug and this side effect and this dose, you forget it. You just can't remember all that. The brain doesn't make you do that. So why don't you just learn the receptors? Say, well, the receptors are always going to be the same. For the rest of your anesthesia career, a beta receptor in the heart is still going to do what the beta receptors in the heart always did. Okay? Positive inotropic, chronotropic, dromotropic, vasodilation, bronchodilation, increased blood sugar, pupillary decrease in intraocular pressure. I mean, you just go down the line. That's what beta receptors in the body do. So just learn that once, and then all you have to know is the drug's a beta stimulant. So I already know. I don't even know the name of the drug. I already know what it's going to do. It's going to make intraocular pressure or my blood sugar go up. Well, then what kind of population are you going to have to be careful giving that drug to if it makes your blood sugar go up? Diabetics, of course. Right. So pharmacology is kind of a logical step to step to step. If you just try not to memorize it, but understand the physiology of what the drug's doing, and it's always going to be the same. You can't change the body. It's evolution, but it's not going to be in our lifetime. So alpha receptors in the body, opiate receptors, histamine receptors, serotonin receptors, whatever. GABA receptors that control wakefulness in the brain. They're always going to do the same thing. So then we just have to figure out what's receptor population is this drug going to affect. And that's how we'll approach this, and that's why you'll remember it forever. So there's 15 beta blockers on the market. They're all given for various heart diseases. You don't have to memorize 15 beta blockers, you just need to know what beta receptors do. So if I block it, what's going to happen? Bradycardia, bronchoconstriction, you know, blah, blah, blah. We're going to learn all that. Now, let's go to page 12. Receptor theory. Number one, in pharmacology, let's learn some terms. There's, when a drug attaches to a receptor, then it's said to be a ligand for that receptor. So any drug that can go and attach to a receptor is called a ligand for that receptor. Now, I'm going off on a tangent already. Look at me. Can't stop myself. Here's a drug receptor theory that pharmacologists don't like because it's too simple. It makes too much sense. You got to make it more complicated because then you sound smarter. But this is, and I think it's a very good analogy. You've probably heard it before in nursing school. All right, it's the lock and key idea of drug action. So here's what happens. They say a drug receptor is like a lock, and the drug is a key. And if you want to open that lock and make something happen, open the door, make the door open, whatever, then you got to have the right key that's in the right shape and the right fit to stick into that lock and turn the lock and open it and make something happen. So the drug's like a key and the receptor's like a lock. And the key has to have a certain shape and a certain size and you know, you get it. You got a bunch of keys in your pocket, right? Your purse. If I want to go out and start my car after class, I got to pull a key out and stick it in the door, unlock the car, put it in the ignition. If it's an old car, it doesn't have a push button, put it in the ignition, turn it, and get the car to start. So those keys would be called ligands. All right, anything that, a key that goes into the lock, a drug that attaches to a receptor is just called a ligand for that receptor. Now, something very important. Like I said, the key has to have a certain shape, size, etc. A drug has to have a certain shape or size to fit on a receptor. In pharmacology, we call it stereospecificity. It has to have a specific shape, size, and three-dimensional stereo structure in order to be recognized and fit into the binding site of the receptor. So if I'm giving a drug for anemia and it doesn't have the right shape to fit into an opiate receptor, then it's not going to cause analgesia. Only drugs that fit opiate receptors are going to cause analgesia. So each receptor has a certain shape, amino acid sequence, and three-dimensional size and shape, and a key has the complementary three-dimensional structure, amino acid sequence, size, shape, and so on. So they match each other. It's like the key fits the lock. They complement each other. Now, take a look at page 12. There's two types of ligands. An agonist is a drug that binds to a receptor and stimulates the function that's supposed to happen. An antagonist will bind to a receptor and block that function. So let me see what I'm saying. I go out to my car after class, I want to open the door, get in and start it. I put the key in the door, turn it, the door opens, I'm happy. that I could say that key is an agonist because it fit into the lock, it made the lock do what it's supposed to do, and I got the door open. An agonist, so let me read it again. An agonist binds to a receptor. The key fits in the lock, right? And stimulates the function that that receptor serves. The function of that lock is to let me open the door and get in. And if that happened, then I'd say that's an agonist action. And let's pretend I take a different key. I go and I put it in my door, and it fits in there. Let's say I can get it in there, but it won't turn because it's the wrong key. I can't get it to open the door. But the fact that it's sitting in the lock, taking up space, means I can't put another key in there, can I? I can't get anything else to go into that lock until I take that one off and I get the right one and put it back in. So if you got a drug that's sitting on a receptor and it attaches to the receptor, but it doesn't stimulate it, it doesn't do anything, it just sit there, then that's going to be an antagonist. It's going to block the body from having a function. Let's say I'm standing here and my heart rate is 60. The reason it's 60 is I'm squirting epinephrine at my SA node, and I'm squirting acetylcholine at my SA node, and there's a balance between sympathetic and parasympathetic, and depending on how much chemical is getting there, it's making my heart rate 60. Now let's say I put a beta blocker in there. Now the epinephrine can't make my heart rate go up. What happens when you give somebody a beta blocker? They get bradycardic. Their heart rate goes down. That's the whole reason you give them. It's to make the heart rate go down, right? One of the main reasons. Why does it go down? Well, they're blockers. They're antagonists. Metoprolol, propranolol, esmolol, labetalol, you name it. They do nothing. They sit on a beta receptor and do nothing. But because they're there, you can't get epinephrine in the body to go there, onto it, and make it stimulated. They're blocking. If that key's in the lock, it's not turning, but you can't get anything else in there until you get the key back out and get things back to normal. You see what I'm saying? So, everything's either an agonist or an antagonist. Either it stimulates something or it blocks something. Up or down. Everything goes up or down. Drugs are all going to do that. And that's how we stimulate them. So both agonists and antagonists are ligands for that receptor. That means they attach to the receptor. The agonist, however, will stimulate it, make it change shape and get activated. The antagonist will just sit there and do nothing and block anything else from happening. See what I mean? All right, look underneath there. I got it in bold. There's two types of agonists and antagonists. Two types of antagonists. They're called competitive or non-competitive. Now, competitive means that they're reversible. Most drugs are reversible. They wear off, right? You pretty much don't want to take a drug that never wears off. That would probably not be good. It would be cheap anyway. But you want it to wear off, right? So what happens is, when you give a drug and it attaches to a receptor, it's going to stay on the receptor as long as the drug is there in a higher concentration than the body's own chemicals are. It's a matter of mass action, the law of mass action. It's physics. The probability of something being on a receptor is proportional to the amount of chemical that's there. If I have 1,000 molecules of chemical drug X and 10 molecules of drug Y, then I've got 1,000 over 10. That's it'll be 100, right?
Yeah.
Took me a minute. So I got 100 times more probability that drug X is going to be on the receptor than drug Y, because it's just there's more of it there. And because there's more of it there, it's more likely to be bound. So it's just basically the law of mass action or probability. So when you give a drug to somebody, and it sits on a receptor, it's going to stay on the receptor until it gets metabolized and it gets carried away from the blood flow and this, that, and 1,000 other reasons we'll get to. And as long as the amount of drug in that receptor is higher than the body's own neurotransmitters or chemicals, then the drug is working. Once the drug level gets low enough, the body's own chemicals will come back. What if I'm talking about the heart again? I gave somebody beta blocker and made the heart rate go down. Well, I stopped giving it. And a couple hours later, it's metabolized, blood level falls, receptor level falls. All of a sudden, there's going to be more epi there than there's going to be drug, and the epi is going to start making our heart rate go back up again. That's called competition. They're competing for occupation of that receptor. Then look at my little thing on page 12. Competitive binding. Drugs compete. What if I give two drugs to the same receptor? What if I give morphine to somebody and they ring the nurse's bell and says, I still got pain, give me something else. And you give them another shot, you give them something Dilaudid. I'm making it up. I don't know. You got two drugs you just gave. Which one's going to be on the receptor? The morphine or the Dilaudid? Well, it's the one that's there in the highest concentration. They're going to compete for that. There's only so much receptor. All right? There's not an infinite number of receptors in the body. They're just proteins. They're in tissues. You only got a certain size. There's only a certain number of them. And once you fill them up with a drug, then it's going to compete with the other drug. See what I'm saying? So that's called competitive binding. Competitive binding means reversible. If something's a competitive agonist or a competitive antagonist, that means it's going to wear off sooner or later because something else is going to be able to compete with it when it's there in a higher concentration. All right, non-competitive means non-reversible. And there's examples of non-competitive drugs. I'm on one of them, aspirin. A lot of people take aspirin, right? Especially old guys like me. Why? Well, for platelet inhibition, makes your blood slippier, you don't have as much heart problems, etc., etc. As we'll learn at the end of the semester, and nowadays aspirin's not really used as an analgesic much anymore, it's a cardiac drug. Everybody just takes it to prevent heart attacks and strokes and whatever. Well, aspirin binds to the receptor, and once it binds, it's there forever. It never leaves. It's non-competitive binding. So how does the blood coagulation get back to normal? Well, you got to make new platelets. That's going to take 5, 6, 7 days to do that. So if I take aspirins every day, little mini aspirins for my heart, tens of millions of people, more and more women nowadays too, are doing that, then it's going to have its antiplatelet effect, but it's going to go away. If I stop taking the aspirin, it's going to take about a week to wear off, because I got to make new platelets that I don't have aspirin on them to make things back to normal. That make sense? That's called non-competitive antagonist. It's not reversible. Now, in the big picture, it is, but it's not reversible on that platelet. Platelet, you got to pee the platelet out with the aspirin on it. You make new ones. That's how you get it to be reversed, right? See what I'm saying? So competitive is reversible. Non-competitive is not reversible. So let's take a look at, I want to take a look at page, well, yeah, we can do that. Give me 1 second. I'm going to page 13. That's what I'm trying to do here. There we go. All right, you should be able to see it, I hope. This is an artist's representation or drawing of a drug receptor. And what he or she is trying to do is show you this. So you follow my little cursor. This is the extracellular fluid outside the cell, in the little tan part. The blue is the intracellular. And of course this is a cutaway or a side look at a cell membrane, lipid bilayer. And that's what they're showing here. And these are all receptors, these orange looking things. And they're showing that embedded in the cell membrane are different receptors for drugs. Receptors are proteins, they're protein complexes, almost always proteins, at least 95% of the time. They could be enzymes, of course enzymes are proteins. And what they're showing here is, see, this is endogenous transmitters. Endogenous means in the body already. Exogenous means comes from out of the body, right? So these endogenous. You see these purple things? One of them, oh, this looks like a mushroom. This looks like a bad hat. I'm not sure what this one looks like. But what they're trying to represent is they're all different shapes. So it's 3 different keys. 3 different shapes. Therefore, only this one that looks like this mushroom fits into this receptor that has the right mushroom hole. See it? And this one that looks like a bad hat fits in this one, and this one fits in this one, and so on. So they have a complementary stereospecific structure that the right agonist or antagonist will only fit in the right receptor. Once it attaches to the receptor, then it causes a series of biochemical reactions. We'll talk about it in great detail someday. And cause the receptor to change shape and some physiological process or biochemical process to happen inside the cell, and you get the effect you want. So this is a little bit about drug receptors, how they work. So let's see what the author said. Proteins embedded in cell membranes generally extend further on both the extracellular and intracellular sides. Attaching to the proteins on the extracellular side are carbohydrate chains, also shown as some protein receptor sites. Arrows indicate the direction of communication. So, that's what a receptor would look like in a cell. If this is a cardiac cell, let's say that's an alpha receptor, and there's an alpha receptor is going to make that cell, give it a signal to, let's say, a vascular cell, going to give this to constrict, cause vasoconstriction. Then this would be an alpha receptor embedded in the cell membrane of the blood vessel, and this would be an alpha agonist that's going to go tell it to squeeze, vasoconstrict. Does that make sense? Here's another one, same thing. Different way to look at it. Same idea, next page. This is page, 14. And so they're kind of saying the same thing. I'm just repeating myself. I love to repeat myself. You're going to see that I repeat myself constantly. I'm a firm believer, number 2, that the best way adults learn is repetition. So I'll repeat myself until, like my wife likes to throw stuff at me. Well, you told me 4 times already. Will you stop it? So, anyways, this is extracellular. This is intracellular. This is supposed to be a receptor, this purple, pinkish looking thing. And they're showing all the different things that can happen. Different agonists can attach, antagonists can attach. Allosteric agonist, allosteric means it binds one place but works somewhere else. So I mean there's a whole ways to different attachments. So it's all the same idea, all right? So then basically, a receptor is a protein in the body that causes some physiological effect, that there's always an endogenous chemical for that receptor. You can't have a receptor without a chemical that works on it. That's not the way the body works. There's always something that works on the receptor. And in pharmacology, we figure out other chemicals that we make up, get them out of plants, get them out of Botox, get them out of somewhere. We man-made them, chemicals. that we can attach to these same receptors and make it more intense, make it last longer, hopefully benefit the patient. Make sense? This is, look at this one. That's kind of cool. I found this picture in a book. I gave the reference there. This is showing a vascular cell, and they're showing all the different these are chemicals that are floating around in the bloodstream that could possibly influence this blood vessel. Prostaglandins, epinephrine, acetylcholine, BNP, angiotensin, and so on. All the different receptors and chemical processes that can be produced, whether they cause relaxation or constriction or whatever. Man, that's a pretty complicated system, isn't it? That's why this class lasts next April. Now, drugs can bind to receptors. They're chemicals, of course, binding to a protein receptor. And there's several different bonds that can occur between a drug and receptor. Go on to page 16. Page 16. And starting at the top, this is a little table. Types of chemical bonds and attractive forces between molecules that are pertinent to the interaction of drugs with their active site on the receptor. And the strongest bond, actually the one that's probably unbreakable, it starts at the top, and then in this little box, you see the arrow here, the yellow arrow. The lower you go, the weaker the bond. So covalent bonds occur, and they're usually non-reversible. That's aspirin binding to a platelet. Ionic bonds, hydrogen bonds, hydrophobic bonds, and van der Waals attractions or forces. These are all different types of chemical bonds that the key can get in a lock, that the drug can attach to the receptor and stick to it with different strengths. Covalent being the strongest and van der Waals being the weakest. Make sense? Okay, the next page. This is a drug reset. This is page 17. And this is a artist's drawing of a drug receptor. And they're showing the receptor here, different domains and different subunits and so on and so forth. And something about this is a beta receptor, see beta. Attached to this receptor, the receptor in turn causes a couple chemical reactions to occur inside the cell, and you get the effect. We're not going to worry about this right now, but I want you to note that if you stimulate this receptor, it in turn causes G proteins to cause release of cyclic AMP, and there's a whole bunch of stuff. If we talked about it now, your eyes would be rolling. So we'll talk about it when you'll care more. Maybe you won't ever care. I'll make you care. Okay, then finally, what I want to end up with today, spend the last few minutes we have together, is talk about dose response curves. So this is page 18. And dose response curve. So this is it. Don't write. Just drink your coffee. Put your pen down. Just let me bloviate here. If you're a drug designer, med chemist, or you work at a drug company, and you're kind of trying to come up with a drug to fix some certain disease, to have some beneficial effect. So really what you're going to do is you're going to have a powder, some kind of powder in a chemical lab somewhere, in a beaker, and you got to figure out how much to give and how much is going to produce what effect, and is it going to do what I want it to do, and whatever. So let's pretend, I'll just make this up, I'll use this example because this is our life. What if it's a drug that puts you to sleep? I think this is going to be a good anesthetic drug. So I'm some chemist sitting on a lab bench with a bunch of powder in a beaker, saying this is going to be the next new propofol. I'm going to retire on a Caribbean island with mint juleps and I'll be rich. So you got to test it. You got to figure out how much to give, what's going to happen, what to look for. And so the FDA requires that you do what are called dose response curves or dose effect curves. And see, this way you can kind of quantify. It helps you put a finger on, measure exactly what the drug is going to be able to do. So you can take, first of all, you start with the kind of lower animals, so some mice, rats, whatever. And let's say I take 100 mice and I give them so much powder and I see how much it takes to put them to sleep and I give it a little bit more and I give it a little bit more and I can figure out how many, and weigh it, how many milligrams did it take to get 100% of these mice to go to sleep. So I can figure that out. All right? It's going to take some time, but I can do it. Or these rats or whatever. So, then I can draw one of these dose response curves. Look on page 18. Look on the screen. So what I'm doing here is this. When I say dose response, I'm looking at increasing doses of the drug. I start with a little bit, I give a little bit more, I give a little bit more, blah, blah, blah. And eventually I'm going to get to a dose where they all go to sleep. And so you're increasing amounts. And you do this on a log scale. You do logarithms. We're not going to do logarithms, I promise. It's been since high school, hasn't it? But remember, logs is a system for using big numbers with, you can just use small numbers and pretend they're big. Right? To the base 10, you use a system of tens. So it's 1, 10, 100, 1,000, whatever. And then, so you put it on a log scale on this dose scale, increasing amounts. And the effect is the effect that you want. Dose response, the response you want, dose effect, whatever. You call it what you want. In this case, we're saying the effect is sleep. Could be, this is a contraceptive, and I want to see if this little mouse gets pregnant. Or this is a drug to treat hypertension. I want to see if the blood pressure goes down. Whatever the drug is, it doesn't matter. You look for the effect. And you'll always end up, because this is a log scale and a percent scale on the effect. This is 0 to 100% with increasing doses. And because of the mathematics of this, you'll get what's called a sigmoidal curve. See, this looks like an S, doesn't it? So it's called sigmoidal, or an S curve. And what happens is this. You start with just a little bit of powder here in the bottom. That's the dose, just a couple milligrams. Nope, none of the mice went to sleep. You get up here a little higher. Oh, this has ended up maybe it was 100 milligrams. Oh, look, some of the mice went to sleep. How many? Extrapolate over here. I don't know, 3% maybe. Can you see my little cursor? Then you go a little higher, and you go higher, and you go higher. Oh, I got to this point here, and I got to the 50% point. Half the mice went to sleep at this dose. Extrapolate down to figure out what the dose is, right? Then you keep going, and you finally get a dose where they all go to sleep. Look at them up to 100%. See it? 100%. So I've characterized a dose from 0 all the way up to whatever it took to get to 100% effect. And this dose response then tells me 4 things. I wrote them for you right on the bottom of the page. What a guy. All right? Number 1, it tells you the potency of the drug. How many milligrams did it take me to get 100% of these mice to go to sleep? Did it take me 100 milligrams or did it take me 2 milligrams? If it took me 2 milligrams, that's more potent than a drug that took 100 milligrams, isn't it? See what I'm saying? In pharmacology, we call it affinity. Because really what we're talking about is a chemical attaching to a receptor. What affinity, what attraction, how much attraction does that drug have to the receptor? The more attracted it is to it, the less you're going to have to give. Clinical people like us, nurses, we call it potency. All right. Potency doesn't mean much unless it's real extremes, one or the other. If a drug X is more potent than drug Y, then you're probably just going to have to take a bigger pill for drug Y. All right, but it's still going to work. All right, so potency, unless it's extreme, is pretty much. So you can tell potency. See it on the scale? Second thing you can tell is efficacy. Look it up here on the top. Efficacy. Efficacy means, in pharmacology, can the drug produce the desired effect? 100%. Can this drug produce 100% of my desired effect? If I could give so many milligrams of this drug, and all these little mice went to sleep, I got 100 mice and they all went to sleep, I'd say I got 100% efficacy. So efficacy just means, can the drug produce what you want it to produce? Up to 100% if you give it a high enough dose. Now, you talk about individual variability. Look on the screen. See this little X thing here, cross looking thing? And that's just to denote that there's variability. And what that means is this. If you went to work on Monday, you took 100 mice, it may take 72 milligrams to put half of them asleep. If you go give the same mice on Tuesday, maybe it took 74 milligrams. All right, there's just an inherent variability for live things, animals, humans, whatever. And there's always going to be a certain variability. You just accept it. Nothing's exactly the same. So they just write this little cross here. Most dosage sponsors don't even write it. They just assume it. And then we never talk about it again and we move on. You just realize if you took Joe Smith, your next door neighbor, who weighs 170 kilos and put him to sleep for a knee operation, he would take 150 milligrams of propofol Monday. Well, the next day he may only take 140 milligrams. Maybe he didn't sleep well the night before. Maybe he ate something funny. There's going to be a certain amount of variability. You just live with it. All right. Then finally, there's going to be, you're able to determine the slope of this curve. See, the S curve. How steep is this slope? That's going to be a matter of margin of safety. I'll show you that tomorrow. You can determine the mathematics of the slope. Remember y equals mx plus b in algebra, high school. I'm not going to make you do that, I promise. But you can determine the slope of a line, and you compare different drugs depending on the slopes and so on. So, to finish off for the day, this dose-response curve, looking at drugs' receptors, I can quantify some of the interactions with drugs and their receptors by doing these dose-response curves. There's 4 things I can tell. Again, it's right on the bottom of page 18. I can tell the potency, or the affinity, same thing, efficacy, variability, and the slope. Okay? All right. Welcome. I'm glad to be here. Glad we're at it. See you tomorrow.